Hello there, I'm Mark Kingston. I'm a researcher at Swansea University Medical School. I'm really pleased to be able to present some headlines from the TRIM study today, and this part of the work is looking at emergency ambulance services calls for COVID-19 during the first wave of the pandemic. The TRIM study is funded through the UK Rapid Response COVID programme with co-applicants and collaborators from the Welsh, East of England, East Midlands, West Midlands and Yorkshire Ambulance Services, and supported by patient and public members and academics at Stirling, Kingston, St George's, Lincoln, Cardiff, as well indeed as Swansea University. So in terms of context, of course, COVID-19 was having a huge impact across the whole healthcare system, including the ambulance services. To stop hospitals being overwhelmed, people with suspected COVID-19 were being advised to contact NHS 111 and 999 telephone services to assess their need for treatment. But of course, ambulance services couldn't then attend and convey all patients. There simply wasn't capacity, so they had to make triage decisions in challenging circumstances and without firm understanding of what works best for patients. If they under-triage, there's potential for harm in patients not receiving the care they needed. And of course, in over-triage scenario, you're unnecessarily using up scarce resources. So what we did, we wanted to evaluate models used to triage and manage emergency ambulance service care, and to describe the triage models used and the categorisation, attendance and conveyance associated with those different models. We did this through a survey of the UK ambulance services, which included a questionnaire and a data request for a 22-week period between February and July 2020. On now to some summary findings for the 12 of 13 ambulance services that participated. Here on the left we present call volume overall, and on the right is call volume for those identified as suspected COVID-19. Overall, across the 22-week period, the call volume varied widely between services. There was a UK peak in week 7 where calls were 13% higher than at baseline. However, all services ended the study period with a lower call volume than at initial baseline. Overall, there were 604,000 calls coded as suspected COVID-19, that's 13.5%. Again, with wide variation between services, which varied between 3.7% and 25.7% of their calls in that period. And indeed in service peaks per week, where one service classified a weekly high of 11% of COVID-19 suspected calls, another service had 44.5%. Overall, case mix and workload changed significantly during the period, and COVID-19 calls displaced other calls. So let's look next at what happened with those suspected COVID-19 calls coming into the ambulance service. How regularly, for instance, were ambulance dispatched, and how regularly were patients taken to the ED or other part of the hospital? So again, looking at the figures presented in the table, we've got a wide variation here across the 12 ambulance services. In terms of, for instance, face-to-face on-scene assessment, i.e. an ambulance was dispatched, that happened in 79% of cases across all services, but there was individual services, it ranged from 59% in ambulance service 3, say, to 100% in ambulance service 8. Meanwhile, in terms of proportion of patients conveyed to the ED, this happened in 44% of cases, but again, ranging from a low of 32% in ambulance service 7 up to 54% in ambulance service 6. So in terms of key findings, we've certainly learned that call volume and level of suspected COVID-19 calls varied over time. We really knew that already, didn't we? But in terms of the variation between services, it's perhaps more interesting. the ambulance services were making different decisions at times for similar patients in terms of dispatch and conveyance. Now, this variation is a flag really for further investigation. The bottom line is we need to understand the safety and effectiveness of the differing triage models to inform care during further waves and further potential pandemics. And indeed, this is what we're exploring in our next stage of the TRIM Phase 2 work, where we're working with 4 ambulance services more closely to compare processes and outcomes of care between the models identified. That's using linked anonymous data. We'll be identifying adverse incidents and cases missed or under-triaged. And we'll link with stakeholders to understand experiences and concerns of clinical and managerial staff about the implementation. I'll end this sort of brief overview there. But I encourage you to get in touch at m.r.kingston@swansea.ac.uk. And finally, say thank you very much for listening.